I think, in general, most of the things in the guidelines are reasonable. They are things I already would advocate. So I think that they are helpful because it synthesizes a bunch of information in one place. It has thoughtful discussions about patients on high doses. It has reasonable encouragement for alternative treatment approaches. I am hopeful that that can be used in a way to potentially improve funding for treatment besides prescribing medications. My fear is that people don't read them very carefully, and they see numbers and they get all panicky about 90 and 50 and other numbers and feel that that is some stopping point or some magic number and applies to every single person the exact same way. It's very clear that individualized treatment is what's needed. That's what patients want. It's what patients need. It's what they benefit from. And it's what thoughtful practitioners should do. However, sometimes systems and people with fear aren't so thoughtful. So I just fear that they are misused and put as limits, unnecessary limits for some patients. So successful opioid tapering can take on many different forms, and it can be where you are basically strong-arming the patient to do it because there's a safety issue, there's a compliance issue, there's some other issue that's making you feel compelled to taper. It can be because the patient has brought forth the issue of tapering. It can be because the doses have been unchanged for a long time. It makes sense to try to explore lower doses. A lot of the time, with patients patients you're treating, patients you've been involved with, it should be a slow, stepwise process. And one of the goals is to minimize the distress associated with that and make it so that it seems like they're doing something positive for their health, because they are, and encourage every little step, every little success. Have a system to support them, so that could be clinic nurses, it could be social worker, it could be an exercise routine that they're starting up, it could be starting alternative medications, other treatments, but slow and stepwise. And if the patient starts having distress, pause, take a break, regroup, and then potentially continue on. So it really depends on who the patient is and why you're doing it, and the speed at which you feel like you need to conduct that taper. Every time you see a patient, it's an opportunity to reassess. Every time there's a refill that's going to require your signature, your DA number, your license, you should think about it, and think about it in a way that makes you just give pause and then go forward. So the things you think about are, is the patient reporting pain relief? Is the patient having serious adverse effects? Do they have any improvement in their function? Have there been any behaviors that are inconsistent with what you've agreed to, whether it be asking for early refills or not participating in other aspects of treatment, whatever it is. Are there any changes in the patient's health status that might make you rethink the medication or worry about drug interactions or anything else? And then it's good every time you're doing this to think, is there anything else I can be doing for this patient to help them with their pain and their distress and their function? So opioids are not standalone treatment. Opioids are a component of treatment. They really should not dominate care. They should be a part of what we do for these patients. And just making sure that we're not missing something every time you do a refill as well. So there's some big stop, do not do any more things. So one is evidence of illegal activity, like forging your prescription, selling the prescription, the complete non-compliance with all your treatment objectives and goals, threatening you or your staff, discovering that they have an alternative source of the medications. In those situations, there's zero reason to taper. You just say, I cannot prescribe for you. And sometimes with those situations, you need to take further action. Those are the rare circumstances in which you might dismiss them from your practice. You might notify appropriate other providers or authorities about some of those behaviors. In the ideal world, opioids should be a small part of what we're doing to treat the patient. Should not be the focus of our management. It should really occur in the context of looking at the biopsychosocial model and helping people function better, have healthy lives, be productive members of society, those kind of things. And opioids can be a component of the effective treatment. When they're a component, just need to make sure that we use the universal precaution idea, that we really know the patient well, take steps to make sure that nothing bad's going to happen when they use the medications, and to assure that we're getting the results we want. And then to not hesitate, to follow through with saying, this isn't really working right if it's not working right. Or if it is working right, continue it. If it's working right and the dose needs to go up, then increase the dose. These are not, it's not like you figure out the dose and it's that way for the rest of their life.